Great. Okay, so thanks everyone for joining again. I'm going to pass over to my colleague Sho, who is one of the public health apprentices in the public health team in Tower Hamlets Council. He's doing that apprenticeship in it's between the council as well as Coventry University. So we're really happy to have Sho with us currently in my team. So I'll pass over to Sho, and then we'll then hear from Sarah, who's also joining us from ELOP. And so if people can kind of hold questions until after those two presentations. But if you want, you can definitely put things in the chat for people to respond to. All right, so over to you, Sho.
Hi, thanks everyone. Yeah, I'm Shoid, or Sho for short. So I'm a public health apprentice working in the Healthy Adults team. And this is just a piece of work that I wanted to present to everyone, really about the public health approach towards the LGBTQ community. So I just want to preface this by saying I might mess up the acronym, so I just apologize in advance. It's just way too syllables for my mouth to take. So I might just shorten it to LGBTQ, but I do encompass everyone. So I wanted to discuss a topic today to create a more inclusive and supportive environment, monitoring LGBTQ status in monitoring forms and the role of trauma-informed practice as well. Through this presentation, we want to explore the significance of collecting this data, the impact it has on trauma, as well as kind of the approaches Tower Hamlets has taken in order to make progressive steps in this area. This piece of work actually came about to form our inclusive monitoring project, which was initially based on findings from ELOP, who is the second presenter, so I'm glad you're here today, and the Tower Hamlets LGBTQI+ community forum, with the overall aims to increase health equity in this community and improving our monitoring, as well as rolling out training towards for our providers as well. So with a nod to trauma-informed practice, LGBTQ individuals quite often experience quite unique traumas, such as discrimination, harassment, and as well as rejection. These experiences can lead to adverse mental health outcomes, can also lead to substance abuse, reduced access to healthcare, as well as support systems. Addressing these traumas is crucial in providing effective care and support. The benefits of having this kind of using the trauma-informed practice method is to create a safe, supportive space for individuals, giving people autonomy and control of their experiences, but also feeling like they're heard, understood, and respected. It's really to kind of foster the relationship stronger between providers and service users, to overall better the health and well-being for everyone, really. So this slide here is really about the things that we can do to kind of implement a trauma-informed practice to create a non-judgmental and inclusive, culturally competent environment. Our literature review and primary data has highlighted kind of these four main areas that needs to be addressed in terms of to ensure that we are more equitable when we are looking at LGBTQI communities, which involve improving the monitoring practices, rolling out a comprehensive awareness training, enforcing anti-discrimination policies, as well as increasing the visibility in services and representation. The trauma-informed practice is embedded in all of these, and to create a safe space for everyone to feel empowered as they come to services. So in terms of the initiatives that Tower Hamlets have done since this project has come about, we've actually updated our monitoring form to include more inclusive language, to allow for people to also self-identify as well. We've also changed phrasing in monitoring forms. Rather than writing words like other, we just say, please specify or please state. And collaborating with providers such as the Weight Management Programme and Smoking Cessation Services in Tower Hamlets. They're all to uptake on training to actually give more support in terms of recording this. And this inclusive approach should ensure that everyone can feel represented and acknowledged. So when I'm talking about monitoring, I'm just defining it as the specific form that we collect data in services about individual characteristics of people in groups. So despite the Inequalities Act, some of the issues that we've identified when making recording this, that is quite a section that's often either left out. Now, this could be a reason, the reason for this could be for a number of reasons, really. So it could be that the person filling in the monitoring form is failing to ask, or the service user perhaps not feeling comfortable enough to be able to disclose their sexual orientation or gender identity. However, it's crucial that we do capture this information to ensure that people do feel kind of safe, respected, and empowered. And we can actually use this to accurately reflect the diverse population of the LGBTQ community. So why monitoring? Monitoring allows us to do many things, and this is the method that we've chosen, as we feel like it's quite a small win that we could do. So monitoring the LGBTQ status is crucial in recognizing disparities, improving areas, and customizing services. Collecting the demographic data, including the LGBTQ status, is vital for more inclusive policies, more targeting resources, and progressive tracking. It also helps us understand with understanding, it reduces stigma and promotes good mental health. Providers actually should tackle discrimination, bias, and stigma to ensure that everyone has access to gender affirming services. These equalities require us to record the data, making it a legal requirement to actually record this. So now I kind of wanted to change topic slightly and talk about the challenges faced by the LGBTQ individuals. Now on the screen here, I have put a number of stats, which we'll share later anyway. So I won't go through all of them now, but I did want to highlight kind of the key message that Dr. Michael Brady highlighted, that LGBTQ plus people disproportionately have more worse health outcomes and experiences to healthcare. Now, we can only assume that this could be that they're perhaps not accessing it or having negative experiences, but I actually wanted to highlight the last stat on the screen there, where it says 80% of trans respondents who use gender identity felt it difficult, with long waiting periods being the most prevalent barrier. And I think that just by having these negative experiences, it might actually deter them from accessing services, thus having poorer health outcomes. So some of the other challenges that are quite generic to the LGBTQI community is discrimination by providers is a significant challenge faced by the community. Bias and stereotyping is quite prevalent, negatively impacting the access to healthcare and its quality of care provided. This can lead to inadequate, ineffective, or inappropriate care, causing physical or emotional harm, which can be long or short term. Withholding information or failing to provide these details about a patient's health status or treatment option is a potential side effect that can result in poor health outcomes. Stigma is another real big challenge for the LGBTQ community. I mean, if we look about the past, historically, homosexuality was pathologized and seen as a mental health disorder, and stigma surrounding HIV and AIDS persists. This is especially prevalent in groups, for example, men who have sex with men, transgender women, and individuals who engage with same-sex behavior. This stigma could influence the decision to seek healthcare services, or therefore provide healthcare providers with culturally sensitive care that is non-judgmental and open-minded. Another thing I wanted to highlight as well about a challenge, which I think is quite important as well, is double jeopardy, where individuals experience discrimination and marginalization based on both their sexual orientation, the gender identity. However, our identities are intersectional, so that our experiences. Research shows that the queer folk from the BME, refugee, and immigration communities are the most at risk of double jeopardy. So this really just to highlight that healthcare providers or providers in general should really provide a culturally sensitive care that is non-judgmental and open-minded, just to make more inclusive care for everyone. Switching topics again, so really the importance of visibility. So really by now you must be wondering, what about privacy concerns when it comes to the relevance of recording this data? It's important to note that any data collected must be handled in line with privacy regulations. And when it comes to relevance, especially what we found in our focus group, that many people didn't know why we needed to record it. However, after explaining about just being more visible and kind of more targeted funding towards their individual needs, the group felt more comfortable after understanding the reasons why we're recording it. However, I'm skipping a bit, and so it really helps us to kind of identify barriers, and in identifying them, we can find ways in tackling it as well. So this slide is just really a call to action about what we can do in our working practices. So I really do just encourage everyone to implement kind of similar practices, advocating for LGBTQ inclusive monitoring in your organizations as well. And it's just really a collective effort so we can work together to create an environment that values and supports LGBTQI individuals. I just wanted to end my little presentation with this slide here. So
don't worry, I can learn.
This was a slide. This is a quote from Harvey Milk, who's quite a prominent LGBTQI activist, and it really resonated with me when I read this. That it takes no compromising to give people their rights. It takes no money to respect the individual. It takes no surveys to remove repressions. So it's really just another call to let's be agents of change, fostering inclusivity and promoting equality for everyone. Thanks everyone for listening.
Thank you, Sho. As I said at the start, I'm gonna pause on questions or anything for now and hand over to our next speaker. So over to you, Sarah. Would you mind, if you haven't already planned to, telling the group a little bit about ELOP, because not everyone may be familiar with the organization. Thank you. Oh, you're on mute, sorry.
That's always a good start, isn't it? I always sum up sort of the issues around monitoring, which is if we don't count, if you don't count us. It's that straightforward. So yes, I'm all in favour of monitoring because it does make a difference. Just very briefly, just very briefly in terms of ELOP, we are an LGBT mental health charity. We're based in East London, and we I guess in some ways you could say we work from cradle to grave, which is a bit of an old-fashioned expression these days, but we work with LGBT families all the way up to working with people over 50. Our biggest service is our counselling service. We run the largest LGBT counselling service in London. We do a whole range of other mental health support. So we do mental health plans, which are about supporting people who are facing crisis, and also about preventing crisis in mental health. We run a trans and non-binary mental health support group. We have a new LGBT men's refit is what we're calling it program, which is around sort of supporting physical activity in terms of sort of physical mental health. We have Recharge, with our mental health support group. We do befriending. We work with young people. We have youth mentoring. We also run some youth groups, 12 to 15s, 15 to 18s, and 18 to 25s. We work with LGBT asylum seekers. We work with LGBT families. In Tower Hamlets, we run an over 50s group and a more generic social support group. And there's probably lots of other things that we do that I'm forgetting. We run a whole range of training, including we have set up a foundation course on LGBT affirmative counselling at that foundation level. And next year we will be launching an advanced diploma focused on LGBT affirmative counselling. And I've probably missed out a whole range of services, but that's a little bit about ELOP in a very short space of time. And my name's Sarah. I am chair of ELOP, so that's my kind of connection. What we were asked to do, so I'm hoping this is, I read this right, was really to talk about our approach in terms of being trauma informed and what we decided to do as an LGBT organisation in terms of thinking about what that would mean for us. And I guess the reason why we started thinking about how we could become trauma informed and why we should become trauma informed is that we were really aware of the amount of trauma that's held within our community. And I'd say almost everyone perhaps apart from some of those very young little ones who come with their parents to our activities, actually have been impacted by trauma. And I think that is the nature of potentially being an LGBT community member. And I suppose we're aware of what that also means for staff. So I'm going to talk about that both in terms of what we've done as an organisation, but also how we put that in the context of thinking about how we support our staff. So our starting point is some staff did the WAVE training. So that meant that we had some really good, ensure we had the knowledge base. I think we had a lot of information about our sort of services are having kind of impacted on trauma, but actually thinking about really being able to unpick it, and that training was really helpful. We then went to the senior team, and the senior team had a discussion about adopting ELOT to become have a trauma-informed approach as an organisation. We set up a working group that's then set up an action plan to look at that, and wrote a policy statement about what being trauma-informed would mean, and then it went to the board, and the board reviewed and kind of agreed that kind of statement, and it also went to the staff team. So some of the things that we've done since then is to do things like ensure that in all our interviews for new members of staff, we have an embedded question about being trauma-informed, and have an understanding that staff, whilst we'll provide training, they also come into the organisation with an understanding that not only is ELOP is trauma-informed, but actually the expectation is that staff themselves can kind of work from that kind of approach. It has meant that we've spent some time thinking about supporting staff wellbeing. We are really aware of, and have been since we started as an organisation, the impact for some of our staff, perhaps going out and delivering training, perhaps working in schools and raising LGBT issues, and then sometimes facing some really difficult kind of conversations. Now, I've had a psychologist, ask whether our brains are different as LGBT people, for example, or our youth workers having run a drop-down day in a school, and the feedback saying, if I had a gun, I'd shoot you all. So that's not uncommon for our staff to face those kinds of responses, and they vary in their kind of, if you like, in their severity, but they all have an emotional impact on our staff. So we've been thinking about what do we do also to support our staff, because that's likely to be triggering for people's own personal experiences of being an LGBT community member, because all our staff and volunteers are from the community, and so we've looked at things like, so we've introduced things like reflective practice sessions for staff. So there's additional time when staff outside of supervision, and our supervisions always have a kind of a well-being element to them, but have some time that's really can be much more focused on kind of exploring whatever they need, as opposed to it being kind of a more supervisory kind of context. And then also looking at kind of the additional support that we can put in for staff. So lots of sort of debriefing sessions and those kinds of additional activities, because it's hard for us to think that our staff and volunteers can work from a trauma-informed approach if we as an organisation aren't supporting them. And also I'm thinking about what does it mean for our staff. So we embed sort of being trauma-informed into sort of all our meetings, into our monitoring, into our training for staff and volunteers, thinking about the language that we're using. And that's been really helpful in terms of, we get very few complaints as an organisation. In fact, we like to encourage complaints, because we think that's one way of trying to also ensure that we can work in the best possible way to explore when things go wrong. But actually to ensure we approach any complaint from a trauma-informed place as well. So rather than it being kind of a defensive place, and staff perhaps coming from a defense of, but I didn't do that even though someone said that, actually to take a step back and to explore why that might be happening and why those things might have been said in the first place. And we reviewed all our policies from a trauma-informed position. We did some training for staff, and this is probably the bit that perhaps I think is more interesting in relation to thinking about being trauma-informed and thinking about the LGBT community, and started to think about where are the concerns for the LGBT community in terms of sort of the traumas that people might have faced, and we did that and unpicked that, because it's useful for staff to be thinking a little bit about recognising about why someone might be reacting in a particular kind of way, or maybe kind of showing kind of signs of distress, and the kind of histories of traumas that people are coming. And the list was quite extensive when the staff were looking at that. So there's something about the wider kind of social and political nature. And if you think about the current debates that are around, both in terms of Parliament, both in terms of social media, in terms of things like with kind of perhaps the Gender Recognition Act and what Scotland chose to do, and then what sort of what the government here has said in relation to that, in terms of kind of the lack of movement on banning conversion therapy, and conversion therapy in itself is obviously an area of trauma that a sizable proportion of the LGBT community has faced. But then if you just think it just in terms of kind of the softer kind of cultural things, like all the emphasis on Philip Schofield currently, all of these things I think have kind of exist in an environment where the community feels very under attack. And that feeling of being under attack and that your rights can be removed. And we've seen that in terms of trans healthcare, particularly for young people. And then the long waiting list has already been talked about for adults, that I think that is very traumatizing for people. And it then also throws people back to some of their original traumas in terms of what it was like being in school and bullying, and what it might have been like to have been rejected from your family. So I think all of these things, have a cumulative, I can't say that word today, effect, but also can be at different times, I think, kind of re-triggering. There are some issues around kind of being outed, and also about when it's safe to be out, issues around lack of visibility, all those microaggressions that LGBT people face. Something also about if people have also had some traumatic experience, maybe as a young person experienced sexual abuse, then actually there are some additional issues around people then say, oh, that's why you're gay, or that's why you're a lesbian. So there's a lot of additional kind of layers that get taken on in terms of people's gender identity and sexual orientation for things that wouldn't be there for kind of people who are heterosexual or cisgendered. So that kind of additional kind of layer of complexity. And that it does mean that often LGBT people start from a position of distrust, because it's hard to know who you can trust. And when your experiences have been of your first service, which is probably for most people being at school, of that not being a safe place, it can then be very hard to know actually who in authority can you trust, and how do you know that you can trust them. And just looking at someone's face doesn't mean, someone might think they're a safe person, but how does someone else know that they're safe? We work with LGBT asylum seekers, and that has a whole nother layer of trauma that people have faced. Some really extreme trauma when they might have witnessed a partner being killed. They may have been imprisoned in their own countries and beaten or raped, and then fled. And we've worked also with young unaccompanied young people who are seeking asylum, and so that goes across the sort of the kind of the groups of people we've been working with. And I guess we also think about people who maybe have come here perhaps on like a student visa, and then they've been here as a young person at 18 or 19, and then once here have realised who they are, and then can't go home. So there's that issue around rejection that can happen in so many different ways, and in different levels of extremity, where it might be just that someone's not talking and can't talk, but actually other people may have faced death threats from their family. So it can go across that level. And then things like the HIV and the AIDS crisis, that particularly the older generation have faced, and that trauma is very much still living with people, with the amount of friends that they may have lost. And then I think when you think about older people in terms of the LGBT community and trauma, people are really worried then about what does it mean when you need care, and who's safe to come into your home to deliver that care, or what will it mean if you need to utilise other services or residential care, and how do you do that in a way that feels safe. So a lot of these things I think can be traumatizing for people. And I was thinking about in Tower Hamlets, we had the murder, and in fact, the person's just been jailed. That's just been released. There was the arson attack a few weeks ago. So there's a lot of things that are just sort of out there in the community that can really mean that people feel under attack and scared, and often then approach services, and often don't approach services for those reasons. But when they do, come with that layer of fear and concern about how might someone be treated. So I guess that's kind of what I wanted to initially say, because I think the political context is really important to be thinking about. And I think the issue around intersectionality is also really important, because we know that you are probably, and it's a probably because it's not, it's all individual, but if you are white, able-bodied, middle class, you are potentially likely, you would have had faced some trauma, but you're likely to have faced less trauma than maybe someone from a more socially deprived background, someone who is a person of colour, etc., someone who's disabled. And so all of these things, I think it's really important to think about the intersectionality and what that means for working in a trauma-informed way. So that was my piece.
Thank you. Thanks to both of you. And yeah, thanks for kind of explaining so much in such a kind of concise and succinct way. I feel like there's a lot to unpack with that. I'll invite, I guess, people in the room to ask questions, but I suppose if it's okay, I'll start with one, which I suppose is mainly for Sarah. And I guess one of the principles of trauma-informed approaches is around trust, and obviously, and part of that is like transparency. But I wondered whether there were things that people who've used, or like who you've worked with, or that ELOP has worked with, where they've said like, or identified useful methods of building trust, particularly with different LGBTQ plus communities. I guess any recommendations that you've heard from people about that?
I guess what people do look out for is to see that they are represented. So kind of those visual representations, I think, are really important for people. So, you know, things like lanyards are one thing, but actually, how else is that backed up? So just wearing something around someone's neck doesn't necessarily mean, but actually, if you can walk into a building and you can see posters on the wall that represent who you are, then that makes a difference. If you see that in terms of things like monitoring, if staff are able to talk and say the words, that makes a difference. So I think it's a whole range of things that, because I think people, you know, obviously it's individually based, but people's antennae are up. People are always, you know, checking out, is it okay? What will that mean? And I think if you go somewhere where you're not on the walls, and particularly if you've got things that for other groups of people, then it becomes, if there's nothing up anywhere on the wall for anybody, that's one thing. But if you've got something up for some of the parts of the community, but the LGBT community is missing from that's an issue.
Okay, that's helpful. Thank you. I'll open it up to the floor if anyone has specific questions for Sarah or Show about their presentations or their wider work. Or comments also. Lucy, go ahead.
It's a thought that keeps festering in my mind. So, because the more I get into thinking about trauma-informed practice, and I've been doing it loads recently, and then both of your presentations have just made me think even more that it's how do we get it out there? Because Sarah, you mentioned about maybe an older adult has to think about the carers they're inviting into their home, or if they're going into residential care, they have to think about how safe is that care home. And so I'm in adult social care, and I'm a social worker. And as a social worker, you know, you can recommend somebody requires, you know, a carer to go in. and then we have to trust that those carers and that organisation that employs the carers that we've commissioned, they're trauma informed and they're not going to be discriminatory and they're not going to re-traumatise somebody. Yeah, it's just a thought. This everything I've been doing recently, I've been thinking, oh no, so we need to ensure that they've had trauma informed training, and we need to make sure it's like a web, isn't it? It's no good for just us to be trauma informed. We need
It
to
really
make
does
sure.
need to be a part of mandatory training, especially if
Yeah,
you're working with service users, just any frontline, just
I've been
to be able to
thinking.
understand it.
Yeah,
That it
so like
exists,
I walk into
definitely.
the council now and I'm thinking, okay, the people who work at the front door, have they had trauma informed practice
Mm.
training? The people that because it's like you say, when you go into a building, if you're on high alert as to can I trust this place,
Mm.
the first person you meet, if you get on the bad foot with them,
Yeah,
that's it. The whole organisation, you're gonna really not.
yeah.
Yeah,
And
sorry,
and I would
digress.
say, and whilst I agree that I think everyone should have trauma informed training, I think what people also need to have is that LGBT awareness, because actually I don't think trauma informed training is actually going to change people's attitudes around LGBT. I wish
Yeah,
it was going to be that straightforward and simple. We'd really kind of, have said that actually things like, and I don't know where you sit in the social care structure, but things like in the KPIs of other organisations who are commissioned, there should be something embedded, obviously trauma informed, but also around, and specifically, not just equalities, but LGBT, because it's really easy for people to hide behind equalities and not then address LGBT.
yeah, yeah. It made me think about commissioning, and we need to think about when we're commissioning home care providers, etc. Are we ensuring that they've got own awareness and understanding of LGBT? Yeah.
And I think it's quite complex, just in terms of thinking about who works in care, what level of training they get given, what people's own exposure has been to a range of differing communities, and LGBT maybe a community that not everyone had exposure to.
Yeah, it just makes me think, because we already know it's an incredibly vulnerable position you put yourself in when you're inviting carers into your home, especially if it's things around like personal care and things like that. Um, and yeah, it's another thing. I think it's something we need to think really carefully about. You've
And I
highlighted
don't
it in my brain.
Yeah, and I don't think social work. I mean, I teach social work. That's my background. I don't think social workers generally are taught to think about LGBT.
Mm,
So actually, lots of social workers feel uncomfortable asking the questions, and there's
yeah,
an assumption that if people want to know, then they'll tell you.
yeah,
And
yeah,
actually, that's not how it works. You shouldn't wait for someone to come out. You should be able to ask the questions.
yeah. Thank you.
Thanks. I was gonna I'll go to Mina because I can see your hands up, but Yana, since you're here, and I don't know if there's any other people that commission services or service providers, it'd be great to hear from your perspective. But while you're thinking about that, I'll head over to Mina. Go ahead, Mina.
Thanks, Angela. Yeah, so thank you both for that presentation. It was great. I think uh, I'm trying to look at this from the perspective of like allyship and how to be the best ally. And I guess I'm also, just as someone who is working on a project within ELFT um, in terms of so the East London Foundation Trust. As it relates to equality, diversity, and inclusion more broadly, I know that intersectionality was mentioned in terms of like how to consider people who have double, triple, quadruple marginalizations. So I guess I just want to know if there was any specific work that's being done around that, as intersectionality is going to be. So I'm working on a project called the PCREF, the Patient and Carers Race Equality Framework, and one of the competencies in that is intersectionality. I feel like not everyone even knows what that means, or like how to like best explain it. So I guess I was just wondering about that, because I know that some people kind of look at people from specific backgrounds and kind of say, well, that person can't be LGBT, that person can't be trans because they're brown or they're black or they're this or they're that, and it's like they have this very fixed view in their head of what someone who is LGBT looks like. And so yeah, sorry, that was a really rambling question. I hope that kind of makes sense.
Yeah, and I think it's really difficult because when I, you know, for example, I, you know, was talking a while ago to a fairly young person, young for me, so probably early 20s, you know, who was a bisexual young woman who was clearly saying, look, you know, I've got a bisexual male friend, we're going to get married because that keeps our families happy. So there's a lot of things can also get very hidden. Because it, you know, and so there's something about how do you unpick this and how do you have those kind of conversations that kind of recognizes that intersectionality of people. And I don't think there's an easy answer to that because I'm not quite sure what you're asking for, but I think it's something about looking at everything you do and thinking about, and how does this apply similarly and different when we put another layer of whatever that might be on into it. So, you know, if we're thinking about, you know, race equality, and then if we put trans into that, how does that differ? What does that look like? If we put faith into that and trans, what does that look like? How does that differ? Because I think that's the only way to kind of to unpick it.
Yeah, and sorry if you don't mind me just coming back really quick. I actually did look into it, and like I found that there are actually these Islamic schools in places like Pakistan and Indonesia where it's specifically for trans people. Well, the third gender community, so not exactly trans. I don't think it's exactly the same. I don't think it translates, but it's sort of similar, like gender non-conforming people. And I was just, my mind was blown because I didn't know that they even had third gender communities in those countries, including my own country, Bangladesh. So I think that's like, I think we think about these things in very Western ways, at least I did anyway. But
I think
actually,
it's just the case
something
of
that
really generalization all the time, and we need to get away from actually just generalizing just by looking at someone. I think I learned that quite early on so previous to this job, I was in NHS, so working in respiratory care, and I really learned the lesson quite early on. I mean, I grew up in Tower Hamlets and right next to Shoreditch, so I was quite used to seeing quite like extravagant people. And there was this patient that came in one day and I was doing a lung function test. And every time we do it, we transferred over to a new system. And I just wasn't comfortable asking what gender are you, because you think if you see a woman in front of you, that's a woman. And this person presented as a woman, and I had no idea about the biometric tests I was taking. It was because I never asked that question, there was a significant change between the results. And that was just really early learning for me, that I found actually you can't actually assume anything and ask all the questions, because unless you're not needing to ask the question, then we only record what's needed, way to think of it. So I think by filling in what's needed, the longer the list is, the more accurate we can target services and like help people as well. That's the antidote for me.
I think there's some I think in public health we're not really that good at understanding intersectionality yet either. Like, you know, we'll look at inequalities data, but usually it'll be kind of maximum two categories of different inequalities. And what does that really even make you understand? I think probably it's more useful to do what people are suggesting, which is kind of raising awareness among professionals about like the different barriers that can be experienced by people with multiple identities, especially where they're like marginalized, and just kind of trying to build trust and find ways to reach out, and not making assumptions like people are saying. So that's really, I'm glad that people are bringing up those points. Were there any additional questions? I think I also the point about third gender communities in different places. I feel like that's also really interesting too. Like there is something similar. I'm from Canada, and I'm not sure if it's for every single nation, but several Indigenous communities in like where Canada is have also a third gender community. But obviously there's been, I think with things like religion, sometimes things can get kind of additionally stigmatized. So I suppose it's about encouraging people to like live with their, like the culture that they want to identify with as well. Jana, come on in.
Yes, just to say a few things about the hostels that we currently commission, the homeless hostels that we currently commission. We gather data around this area, and we do have, the gender reassignment and, different gender identities. So we monitor that, and every year we gather data from the hostels, male, female, or mixed hostels, mixed gender hostels, on this diversity data. And we also monitor any activities that are happening in the hostels. Usually the hostels celebrate the communities, the LGBT communities, which is great. And they send us a lot of information around that. Additionally, we have asked Positive East, which is a fantastic agency in Tower Hamlets and beyond, to support the hostel staff as well as the residents to come and discuss sexuality issues and also have medical tests, because these are very sensitive conversations and very I would say it's very, very difficult for people who are not trained, and they are supporting people who have been homeless on the streets, and they support them to do the benefits, register with a GP, to hold these conversations. But also it's a matter of trust, for obviously the homeless population who have been on several occasions let down from different professionals, including medical professionals, social workers. Not to blame anyone here, but as people said, the awareness sometimes is not there, and sometimes the approach is not so trauma informed. So we have partnered up with this lovely agency who supports us, goes to the hostels, does a lot of training around LGBT issues, both physical health and mental health, training the staff and also training the residents, which is fantastic, I would say. Plus, they also support the hostels on one-to-one basis on cases. And our vision is, because we are now going under procurement, to put more additional staff in our service specifications around these areas. So that's the input from the hostels.
Thanks, Jana. That's really good to know. And good to hear that you have partners that people seem to trust. I wanted to ask another question linking back to the trauma-informed principles, I suppose, because a few of them are related to, I guess, like power sharing, whether it's through peer support or other forms of collaboration with service users or residents. And I wondered if you have come across like useful examples of that where, and like what kinds of things did you need to put in place to make that feasible or that people would want to be involved in?
So I think it depends on, because all our services are quite different. But I think what's for us has been interesting has been about what's happening in our groups and how much of the support in the groups very much becomes peer support, even though the groups are facilitated. But I think that takes some work and skill from the facilitators to get that to that place. I think for us, one of the challenges has been is that we're still working online because we can't move back into our building because it's not fit for purpose anymore. We've outgrown it, and that has been, I think that's had a real impact on some of the things that we would kind of organically do that we haven't been able to kind of do in the same kind of way because people aren't together in the same kind of way. Yeah, so it'll be interesting to know what other people are doing in relation to this, because I think that's an area that we could continue to develop.
I guess one example might be the LGBT community forum, which, although it's not specific to services, it is about or like one service, I mean. It is about kind of encouraging participation and representation. So do you know much about how people view forums like that, and like how that could work in other instances?
Yeah, and I think the forum is a really interesting example of how people can come together, and very different people can come together, but also what people want from a forum can be very different as well. So it's interesting about whether people kind of come together because they're interested in a particular topic that the forum may be working on, which brings in some people, or whether some people are there because they want to make kind of connections with other people. So that could be very variable. I think that, and it's interesting, across London, the experience of LGBT forums are very different. So it does very much depend on which borough you're in, to whether there is a forum and how those forums work. I think the Tower Hamlets forum is quite interesting because it's very diverse, and is representative of kind of the diversity of the borough, which I think is potentially quite unusual, because some forums are much more weighted to more middle class, more white, and then potentially the Tower Hamlets forum is. So I think that's also interesting about kind of how you can do that. And for us, it was also about making the links with a kind of a range of sort of very small kind of community groups and gaining the trust of those groups, that then enable people to feel that they could be part of the forum, and kind of thinking about what is it that we need to do to make us as open as possible for people to feel like they can be part of the forum.
Sorry, I was on mute. That's good to know. I feel like it's kind of, I guess, promising to hear that the forum in Tower Hamlets is more diverse than you might expect or see in some other places. So that's helpful. And if people in the call aren't familiar with the forum, I'll send out the link to it after, in case you ever, I've worked with the forum before in terms of like consultations on specific projects, but in case it's something that you want to engage with more, that could be one option. So I'll definitely send a link for that out after this. Got time for probably one more question, or if our speakers have any kind of like final statements or questions to the group that you might want to ask. Okay. Thanks everyone for joining. And thank you so much to both of our speakers for each of your insightful presentations. And I'll send out the slides and the recording after this, although my email is not working currently, so it may be tomorrow. But you can look forward to seeing that, and please do share it with colleagues that weren't able to join. Thank you, and have a good rest of your day.
Thanks everyone. See you.
Thank you.
Take
Bye-bye.
care.
Thanks for having me.
Thank you.